We'll get started in just a few moments here. I see people are still joining, so we'll wait until the joining slows down a little bit.
Interpreters on the call that haven't gotten permission, please use the chat function to let us know.
Okay, we have about half of the registered participants online now, so we'll go ahead and get started. Welcome, everyone. Thank you for joining us this morning. I'm thrilled to begin this seminar series for the NIH Library on the All of Us research program. I'm Cindy Sheffield, one of the biomedical librarians here at the NIH Library. Dr. Sherry Schuler will be telling us about the All of Us program in just a few moments, but I want to just touch base on a few quick housekeeping items, as well as let you know about some of the NIH services we have here at the library. So this session is being recorded. The slides and the recording will be sent to everyone who is registered for the program. Use the Q&A option for questions. Questions will be answered when the presentations are completed, but we will be monitoring the questions throughout the presentation. We'll get to as many questions as possible, and please be sure to fill out the survey after today's presentation. Just a few quick notes about navigating the Q&A feature. If you just click on the Q&A feature at the bottom toolbar of the meeting window, then view submitted questions and responses and comments. You can submit a new question. You can comment on submitted questions, and you can use the thumbs up icon to upvote questions if you'd like to do that. Upvoting makes it easier for us to know what questions are of most interest to participants. Then just a few words about the NIH Library services. We do here in research analytics have a bibliometric service that provides publication analysis to staff as well as other services. We also provide access to bioinformatics and analysis tools and databases and related training. In database services, we provide information on data management, data visualization, as well as many other coding languages such as R and Python. Or perhaps maybe you want to use our virtual public workstations using applications such as Partech suite of tools, MATLAB, SPSS, SAS, NVivo, as well as many other software applications. You can find information about this on our website, or feel free to contact me directly. My address is there at the bottom of the screen. Also, we offer several training programs. Here's a highlight of a few of the training sessions that are coming up in both April and May. So as you can see, you can cover everything from Python to SAS and pivot tables in Excel, excuse me, during April. So without further ado, first I want to introduce Dr. Ruben Basker. He is the program officer and research engagement, and outreach branch director within the NIH All of Us research program for the engagement team. He is excited to be working with the team that helps maintain the essential relationship between the program, participants, and community partners. And prior to his current position, Dr. Basker began working in the All of Us research program as part of the American Association of Advancement of Science in their Science and Technology Policy Fellowship. His interest in health policy began during his graduate work at Vanderbilt, where in addition to researching mechanisms of disease and signal transduction, he gained an appreciation for the effects of policy on human health. Dr. Basker received his doctorate in clinical and cellular biology from Vanderbilt and his bachelor's degree from Washington University in St. Louis. So without further ado, Dr. Basker, I'll turn it over to you.
Yes, thank you so much, Cindy. So as you've said, I'm Ruben Basker. I'm the Researcher Engagement Outreach Branch Director in the Division of Engagement Outreach at the Alvis Research Program. And the Alvis Research Program is one of the largest and most diverse data sets of its kind. So rather than cover an overview, how to use it, and resources to help you use it in just 1 hour, we'll actually be doing this as a series. So after today's intro, you can join us in April 12th for how to register, on April 19th for an in-depth look at the data itself, April 26th for data analysis using coding, and May 3rd for resources available for researchers. Now, you'll notice that these events are occurring on a weekly basis, except for next week, which is the All of Us Researchers Convention. So if you're interested in what other researchers are doing with the All of Us Research data set, this is a fantastic event for you to attend. And so before going into the program and introducing our next speaker, I'll actually give a very brief overview on the Division of Engagement and Outreach for the program and the Researcher Engagement and Outreach branch within it. So the Division of Engagement and Outreach is organized into 4 branches, and these are focused around participant and community engagement, tribal engagement, operations and dissemination, and finally, researcher engagement. And while the focus for each of these branches is different, the foundational approaches for each of them is the same. And each branch works within an All of Us engagement ecosystem. So this we can see on the next slide, and it will show that foundational elements of engagement underpin all of our work. And these are concepts like trust, bidirectional relationships, and creating dialogue between science, research, and communities. And so using this foundation, All of Us has a wide reach through its national partners and deep connections to communities through various funded partners and outreach leaders. And these partners, along with participants and consortium members, make up the engagement ecosystem. And hopefully by the end of this series, you'll consider yourselves an active part of this ecosystem as well. And so we're very lucky to have as our first presenter for this very exciting series, Dr. Sherry Scully, who is the Deputy Chief Medical and Scientific Officer and lead for ancillary studies in the All of Us Research Program at the National Institutes of Health. And so through her leadership, she is establishing ancillary studies as a core and scalable capability for the program that will help expand the cohort and deliver new phenotypic, lifestyle, environmental, and biological data to the All of Us Researcher Workbench, offering more diverse data types to researchers like yourselves. So she's helping ensure that if you don't have a data type that you want right now, you just have to wait. Dr. Shelley, without further ado, I'll turn things over to you. I can think of no one better to introduce the program.
Great. Thank you so much, Ruben. And I'm so excited to be here. Wanted to talk a little bit about how All of Us was formed and sort of what our central goals are, and then really get into the types of data that we have available for researchers. Happy to take questions at the end, as Cindy mentioned in the beginning. So the All of Us Research Program was first funded through the 21st Century Cures Act, which was signed by President Obama in 2015. And it is part of the broader precision medicine initiative that was part of that 21st Century Cures Act. We have core values that really drive All of Us. And these core values were set forward in the advisory committee to the director of NIH around the Precision Medicine Initiative. And really, these core values fuel our purpose and shape the vision for the program, as well as help us with the implementation of that mission. So the first is that participation in All of Us is open to all. Our participants will reflect the rich diversity of the United States. Our participants are partners in the research that we're actually doing, that trust will be earned through transparency, that participants have access to the information that we have on them, that data will be accessed broadly for research purposes, one of the reasons I'm here today, and that security and privacy will be of the utmost importance to everything that we do as far as dealing with data from our participants. And finally, we really truly hope that this program will be a catalyst for positive change in research, not only around engaging our participants as partners, but also in that data sharing paradigm where we can really make data broadly accessible to anyone. So our mission is to accelerate health research and medical breakthroughs, enabling individualized prevention, treatment, and care for all of us. And we really do that in 3 ways. And you'll hear the core values that I just mentioned throughout our mission. So the first is nurturing partnerships for decades with at least 1 million or more participants who reflect the broad diversity of the United States. Second is delivering one of the largest, richest biomedical data sets that is broadly available and secure. And third, just because we have these partnerships and have built this amazing infrastructure doesn't mean that necessarily people will just come, right? So we want to catalyze an ecosystem of communities, researchers, and funders who really make all of us an indispensable part of health research and that catalyst for change that I talked about. To date in the program, we have over 775,000 individuals who have consented to be part of the program. From that, about 533,000 have done all the initial steps of the program, including doing an in-person or virtual physical measurements, as well as a biospecimen donation, and completing our first 3 surveys, and consenting for use of electronic health records in research purposes. We currently have linkages to over 431,000 electronic health records and biospecimens on over 550,000 individuals. On the map here, you can actually see that we have participants in all 50 states, as well as several US territories. The darker shades of yellow that you'll see there are actually where we have higher concentration of participants. And that is largely because that's where many of our health provider organizations are. These are typically large regional medical centers where people actually go to get enrolled. And the numbers within each state actually indicate how many participants we have per state. And so you can see that we definitely have a national reach with some concentrations being higher than others, but we really are trying to meet people where they are and reflect the broad diversity of the United States. And when I talk about diversity, I'm not just talking about racial ethnic diversity. We really strive to include those who have historically been underrepresented in biomedical research. And so the current clinical guidelines that are available are based off of research studies that have been done in the past. And these typically haven't include racial and ethnic minorities. They have not included people of low income or low SES. It's not included sexual gender minorities or people with a disability. And really, so we're trying to really hit a broader swath of diversity than just race and ethnicity. I will say that one of our key tenets is to have a underrepresented in biomedical research percentage of 75% or more. Ours is actually closer to 80 right now. And to really focus making sure that we have a racial and ethnic diversity of around 50%. So far, what we've been able to do in that space has been groundbreaking. And if anyone's interested in learning more about our engagement framework from Ruben or others, we're happy to engage on sort of how we're going about this meaningful connection with these communities that have not been part of research to date. But from what we've collected, we've already seen an amazing amount of diversity. And on the right-hand side here, I really have some genetic analyses that were done, and they're actually available on one of the resources that I'll talk to you today about called the Research Data Browser. That we've, other genetic studies are on the bottom there. They tend to be very focused on of European descent or white populations, typically much more affluent, higher SES, higher education. And the All of Us research program is really trying to expand that. And so genomics is just one example, but many of our data types, we're seeing things that have never been seen before, because frankly, these people have not been part of the research enterprise to date. Our basic protocol starts out with a consent for use of electronic health records in research. And currently with the electronic health records, we're pulling demographics as well as vital signs and diagnoses, procedures and medications, as well as visits. We do have a number of surveys that we have deployed over time, including the basics, which is basic demographic information, overall health and lifestyle, healthcare access and utilization, personal and family health history, social determinants of health, and then a mental health and well-being survey that we recently launched in 2023. At in-person enrollment, we actually collect some physical measurements. Those include blood pressure, heart rate, height, weight, BMI, and hip and waist circumference. And we collect biospecimens on our participants. And so the primary biospecimens that we collect are blood and urine. If we cannot collect blood, we actually will collect saliva from our participants because we do genotyping and whole genome sequencing on all participants. We also are able to link to wearable data. Right now, we are linking to Fitbit, and we'll be soon moving to Apple Health Kit products as well. And there we really pull out heart rate as well as a daily summary of activity and intraday steps, as well as some sleep data. So you'll hear me talk a little bit more about all of these as we go through the presentation, but this is our overall base protocol for all of our participants. I also wanted to point out that I mentioned earlier that one of our core values is that participants will have access to their information. And so we really do strive to make sure that we are returning value to our participants so that they feel like they are actually part of the research enterprise that we're engaging in. I will go through some examples of genetic information that we are returning back to our participants. Also, with surveys, they get results of their surveys with some comparisons to where they might be fitting in with others. We are actually giving back EHR data so that if people have multiple EHR providers, they can actually see all of their information in one place, which has been super valuable. They continue to get ongoing study updates about the overall study and any ancillary studies that they may be enrolled in. Aggregate results and scientific findings from what's coming out of the program, as well as opportunities to be contacted for other research opportunities. So I'm just going to talk a little bit about the genetic return of results that we are doing as a program. And keep in mind that this is our major effort to really give back individual results to participants. In some cases, we may not be able to give individual results back, but that's where we sort of get more into the summary statistics as well as educational materials for our participants. So the first thing that folks get back from the All of Us research program are genetic ancestry and trait results. And so we give back 7 regions with 20 subregions to participants. So it's a pretty high level that's, more or less continental, but they can sort of understand that these are where their genetic ancestors came from, not necessarily their parents or close family members, but ultimately sort of where they came from in sort of historical times, as well as traits. So we give back earwax type, bitter taste perception, cilantro preference, and lactose intolerance. So these are sort of what we call engaging insights, fun things to know about yourself. And people have really found that valuable. I'll get into some data of what that uptake has looked like so far. We also get back 7 pharmacogenomic genes and a list of medications that might be implicated in use with pharmacogenetics. And so people really get a report on the variation within these 7 genes, and then a list of medications that really could be affected by these. And then finally, we do give back health-related return of results in what we call a hereditary disease risk report. These are the 59 genes that were recommended by the American College of Medical Genetics that actually have actionable things that people can do if they have a pathogenic variant in one of these genes. I will note that for the health-related results, we actually will not return a pathogenic mutation to a person without use of our genetic counseling resource, which is at Color Health. For any of these reports that people get back, they are free to call a genetic counselor at Color Health, which is part of our program, so that we're responsibly returning these results to folks and so that they know what to do if they have something that seems pathogenic within their genome. This is just an example of some of the reports they actually get back. You'll see here on the right-hand side is sort of the genetic ancestry and traits. As I said, it's very broad ancestry that gets returned back. For the hereditary disease risk, you can see here's one that's an example of someone who has a mutation in their BRCA1 gene. As I mentioned, in order to get a report that actually has a pathogenic variant, you have to go through a genetic counselor. We want to make sure we're doing that responsibly. And so far, over 222,000 of our participants have been offered a disease risk report. Many of those will have no pathogenic mutations seen in those 59 genes, but about 3 to 5% will have something. And so of the 222,000 that have been offered it, over 53% have said yes, that they would like to know the results of that. And almost 100,000 have actually viewed those results. And about 3% have had an actionable result or actually found something in one of those 59 genes. For the pharmacogenomics, or what we call the medicine in your DNA, we have all the same number was offered. About 52% said yes, with a little bit less actually viewing than the hereditary disease risk. And almost 96% have some sort of actionable result within a pharmacogenomic gene, which is totally in line with what's in the literature. Again, at any time, folks can actually contact a genetic counselor to see what that means for them. And then as far as like our engagement traits, we actually have had almost 300,000 of those offered back, and a much higher percentage, 63% have said yes, they'd like to see that, and a higher rate of folks have actually gone in and viewed those. So, you know, when we first started out the program, we expected to see a lot of people wanting to know more about the health-related return of results, but what we're actually seeing is that more people want to see the engagement traits and not necessarily much more of the genetic health-related return of results or the medicine in your DNA. So with all that in mind, we have been collecting data since 2018 when the program first launched. And so I'm going to launch in a little bit about what's in our data set and how you can go about getting access to it. So first, I just wanted to give a little primer to what the different tiers of data look like. And so I'll start out by talking about our public tier of data. This is something that any one of you can search right now. There's no login required. It's at researchallofus.org. Don't worry, you'll see QR codes and lots of prompts to getting you to go and looking at this resource. But on that public tier of data, which I'll go through in a minute, you can actually look at data snapshots that sort of give current enrollment in the program, as well as for the different underserved populations, what our enrollment looks like. There's actually an interactive data browser where you can actually look across different data types and see what's currently in our data. That's really helpful for helping to think about the research questions you might want to ask. We have a survey explorer, which details every question that's in our surveys, as well as the source material of where these came from. We typically try to use validated surveys as much as possible so that we can actually have common data elements with other large cohorts. But you can actually see the source material for yourself, as well as a research projects directory. So for every user that's on the researcher workbench and all of the projects that are being done, we actually ask for a short description, sort of like an abstract of what the investigator is looking at and sort of what they hope the outcomes to be, and you can actually search that. Then we have sort of what we call the researcher workbenches, which is much more of a protected space. And so registered researchers can get more in-depth data. They can do cross tabulations across different data types and really dig into things such as our genomics and EHR data in a more meaningful way and actually get row level data. And so these different tiers between the public tier and the much more protected tiers really allow us to have more granular information as we go up in sort of the expectations of, you know, signing on with a data use agreement, registering as a researcher and things like that. But that public tier sort of gives a good swath of sort of what's in our database so that you can start to ask questions and think through things as you're starting to plan what study you might want to undertake. I mentioned earlier how many participants are actually enrolled in our program. We release a data set approximately one time a year. So currently in our current data set, we have survey responses from over 400,000 individuals, physical measurements from 337,000 individuals, electronic health records from 287,000 individuals, whole genome sequences on over 245,000, as well as some long read and structural variants within the genomic data set, and then almost 16,000 individuals with Fitbit records. So once we got all this data together, this database here, just the genomics itself, includes variation at more than 1 billion sites that have never been seen before, which is nearly 1/3 of the entire human genome. And that's really a testament to the amount of diversity that we're really striving to have in the All of Us data set. Now, I mentioned that we update our database about once a year. So each of these numbers will grow over time as we have more data coming in, but we will also be adding new data types as the new data sets come out. So you may see additional long read sequences, you may see additional Fitbit. But then as we start to add in other types of data that we're collecting, you'll start to see other little bubbles showing up with how many participants have actually done those things. And so it's a dynamic data set. It's locked in for approximately a year. You can actually move from one version to another as it sort of comes out. But this is much more of a dynamic structure than someone sitting on the data for years, making sure it's clean as can be, and then putting it out. This is really sort of a dynamic situation with the data, and it's growing over time as we're engaging with our participants. I mentioned that I was going to do a little snapshot of our public data browser, and that's exactly what this is. This is an example that I did just looking at cancer, really high-level term of cancer. I didn't really dig in too deep. But you can start to see that if I put in cancer, it searches across all of our data types. And actually, you can hover over each one and sort of understand for EHR conditions, how many do we see there? For labs and measurements that are in the EHR, for procedures. And then you can dig into our survey questions and even physical measurements that might be associated with what you're doing. I want to point out that we also sort of can give high level counts as well as graphs and things that sort of might be useful for presentations and other things, just to get an idea of what's in the database. And so you can see here, if I'm looking at just malignant disease, there's over 50,000 individuals who have EHR conditions for that. You can drill down even a little bit more. When I clicked on that 50,000 there, I'm able to look at sex assigned at birth. I'm able to look at age and sort of what the source code was and how I got there. You can note that I can't do sex assigned at birth and age. Those are cross tabulations that sort of get into more identifiability. So we try to keep it very high level in the data browser. But you can see there is a lot that can be done just within this publicly available source. You can also look at the survey questions. So this is a screenshot from the personal and family health history, and you can actually see the responses there. And again, if you clicked on the arrow that's all the way to the right-hand side, you would actually be able to get graphs and things, just as I showed with the EHR data. So the controlled and registered tiers are the ones that really you have to sign in and have an account with the All of Us Researcher Workbench. The QR code at the bottom is something that's easily to scan and actually go right to that to figure out how to get into the Researcher Workbench. Ruben also mentioned that we will be having a session on that, how to set up your billing and all that kind of stuff, which is super helpful for someone who's just starting out. I have mentioned already that you have to have a count, you have to have a data use agreement, which is actually with the institution. Many institutions here at NIH already have those data use agreements, so that should be relatively quick. I can say that we've seen for people who already have a data use agreement in place with their institution, you can actually get into from registering the data, taking our responsible conduct of research training, and into the data within the same day, which is sort of unheard of as far as like data access and what you can actually do. We have a cloud-based central resource for this. We really create virtual workspaces on the cloud. And so you don't pay for data within the All of Us Research Workbench. You actually pay for compute time on the cloud. We start everyone off with $300 in compute credits. So everyone is, starting from a level playing field. You're not allowed to download the data. It's actually, everything is done here within the workbench and stays sort of in your workspace. But that really actually sets a level playing field for those who, haven't had access to large compute resources at their institutions. It, levels the playing field for those who may be citizen scientists and things like that. So it allows us to reach a much bigger population by having this cloud-based platform. It also allows us to understand how our data is being used in much more granular and meaningful ways. So within the Researcher Workbench, we actually have some point and click tools that actually can help you build your cohort as well as the data set that you want to evaluate within that cohort. Currently, you have to know how to code in either R or Python and be somewhat familiar with Jupyter Notebooks in order to really analyze the data within the Researcher Workbench. That's why I love seminar series or workshop series just like this, where we go through and actually tell people how to go about doing things, showing tips and tools so that, that compute time is not spent really investigating the resource, but really using it and digging into the data. We are going to be bringing SAS on board pretty soon. It's actually going to be a game changer for the field because SAS typically hasn't been used on cloud platforms before. So this is actually a new use case, which I think will actually be super helpful for folks who do more of the epi and public health work. And I mentioned at the very beginning that we really want to be a catalyst for change in research. We're actually employing something called a passport model for data. And so if you think about the traditional paradigm of how you go about getting data, you get one data download, and in order to get that, you had to go to a steering committee of the cohort, ask for permission for the data, spell out exactly what you were going to do with the data, what data types you needed, et cetera. With the passport model, you actually get to explore the data much more. We do ask that for every project you start, that you actually enter it in the research projects directory so that our participants and other researchers can see what's being done with the data. But you have a passport now, meaning that you can start new things and pull in new data types and be much more dynamic. And we were able to get an IRB approval. So all of this is non-human civics research, so it can be done in a much more fluid way. We're currently open to academic, healthcare, and not-for-profit organizations. Last year, we actually started to open up to international space, and we will be expanding the access hopefully later this year. I'm going to go through a really quick example of doing a GWAS study or genome-wide association study of type 2 diabetes. So the first step is you would create your workspace and you would define that and write a research projects directory entry. Then you could use the cohort builder to point and click. I would like to see both women and men in this age group with these sort of sets of criteria. And then you're able to pull in a data set with the point and click tools of sort of what concepts you'd like to see. I'd like to see what medications they're on. I'd like to see the labs that they have. And then it actually helps to form a data set. And these are really easy point and click tools. And then analyzing that is really within the Jupyter Notebook platform. And this is where the R and Python really comes in. And so you can see sort of an output from the Jupyter Notebook there. But we've tried to take everything upstream and really make it as easy as possible for using. And I will say that we are very open to hearing feedback about what's working and not working within the system. So at any time, we encourage you to reach out and let us know what you like, what you don't like, what you wish you could see here. Doesn't mean that necessarily we will be bringing up, but if we hear from enough people that we want to have something like SAS on board, then we start to move towards that space and make that available for all users. All of us is a disease agnostic cohort, but given the size so far, we have seen a large range of diseases and conditions within our set. So this is just a very broad look at sort of our counts of various diseases within our population. And our electronic health record data and actually Fitbit data as well actually is longitudinal. And so even though the program started in 2018, for many of the different EHR, excuse me, values, we can go back into the 90s. So we're actually getting folks when they were kids or teenagers and sort of see their age throughout the process within our EHR data. We've actually been able to double our digital health as well as EHR connections in 2023. So if you remembered back in the initial slide I showed 533,000 individuals are part of the program. We have only linked to 430,000 EHR records. We're trying to close that gap a little quicker. And so we've been really trying out new methodologies about how we can go about obtaining electronic health records for use in research purposes and have been able to really accelerate the timeline on that. So what kind of research can all of us support? I think you can probably think of a lot of uses. I've put a few here. One is sort of associations between different diseases, medications, social determinants of health, and genomics. Certainly health equity and health disparities research is one of the things that we really are promoting and really hoping to make a dent in. Of course, many genomics and pharmacogenomics studies, as well as drug targets and things like that. You can think of anything. Some of the things that our researcher workbench can actually support include artificial intelligence and machine learning, risk stratification, doing some different algorithms and cohort development. And you can add, whatever you can think of here. The value of all of us is really not just about one data type, though. I will say that the value of all of us and how we're really going to realize precision medicine for everyone in the US is by the combination of the data types that we use. And so having this very powerful cloud platform allows people to start to bring in different data types that really haven't been investigated thoroughly, especially not in these populations. And so you can start to think of the questions that can be answered from the data that we already have, and then how that's going to grow over time with the new data types being brought in, the larger sample size, people developing disease over time, because we're actually following these folks over time. And really the power of all of us becomes exponential. I will say that all of us is not a representative sample of the US. We are purposefully recruiting folks who have been underrepresented by medical research. And so we are, in fact, reaching out to people who have not been part of research and therefore have an overrepresentation of those folks within our cohort. I put together here sort of some distributions between the census, NHANES, and then all of us. I definitely come from a population genetics and epi background, so this is the sort of thing that I love to do. You can see that for all of us, we definitely have skewed things in sort of our demographic information. And as I mentioned before, that's purposely done. But what we're trying to do is actually come up with weights and sampling strategies that people can actually compare to other resources, including in Haynes and census. And so not in working order yet, but we are currently creating synthetic sampling weights that people can actually pull into their analyses so that they can make more generalizable comments about penetrance and things like that, and not just within our cohort, but actually comparing different groups. I mentioned before that you'd see this QR code again, really easy to get access to this resource. The first thing you do is make sure you have a data use agreement at your institution, which we're calling a DURA. Many of the NIH institutes already do. Create an account and verify your identity. Complete the mandatory training, which is a responsible conduct of research training that we put together. And really helps you understand sort of with some of these populations who have been stigmatized in the past, how can you avoid doing that within our data? And then finally signing a data code of conduct, and then you're into the data. And as I mentioned, sometimes that happens relatively quickly and sort of not what you're used to in your usual research paradigm of waiting for data. We have just hit the 10,000 mark. So we have 10,000 users using our data, registered users. This slide's a little bit out to date. We are really pushing for researcher diversity as much as we're pushing for participant diversity. And so, part of that power of having everything on the cloud is that we're able to reach out to historically Black colleges and universities, minority serving institutions, high schoolers, undergraduate programs, things where it wasn't really possible because of the amount of compute power you needed to get some of these genomics and other big data sets into what you were doing. We've had over 350 publications already using the data. And I'm sure this number is already out to date, but over 700 organizations using the data just in the US. We want to continue to push for a diverse researcher cohort, as well as encouraging students and early stage investigators. This is a great opportunity to think about questions that you may have and gather preliminary data for the R01 or the next grant you want to write, or even intramural proposal that you want to write. We want to ensure access from various institutions, as I've already mentioned, and we want to make this truly an equitable resource for all. And so along with sort of what we're doing for metrics for diversity within our participants, we're also really shooting for a high number of people from what we're calling underrepresented in the biomedical workforce, including those who are diverse by racial and ethnic backgrounds. We have a growing scientific impact, as I mentioned already, over 350 publications and going, and this is just going to keep growing over time. And I want to give you a hint about where we're going and future opportunities that we have. The first is we launched a beta version of our pediatrics at the end of last year. We're going to be bringing on more genomics, and so we're going to be moving into about 400,000 whole genome sequences with over 1,500 long read sequences, meaning that you can start to see copy number variation, structural variants, and things like that. More wearable data from Fitbit, as well as new data from surveys and other things. We are also going to be bringing in linkages to other data sources that are out there, including environmental data, claims data, disease registries, and more. And then, as Ruben mentioned, we're really trying to stand up ancillary studies and really bringing in diverse data types by having targeted data collections around various topics. We have just launched our studio on the researcher workbench, which should make it a little bit easier for, it's the R version of a point and click interface, makes it a little bit easier for some of the genomic analysis. So that has just launched on our researcher workbench. And as Ruben mentioned, we've been really celebrating our All of Us Researchers Convention, which takes place next week on Wednesday and Thursday. It's free to register. It's completely virtual. You can sign in and sort of see what people are doing with the data set, hear from some of our leaders on sort of where we're going with this program. Yours truly will be one of those presenters. So really looking forward to it. I love to see what students and others have sort of done with the data, and it's really amazing at sort of the capabilities that people are able to do. So with that, certainly none of us can do this alone. We have a huge consortium of partners from across the United States. Every time this slide is shown, the graphics get smaller and smaller because we're constantly growing. And then our provider and community networks, which really help us have those meaningful engagements with those individuals who have been traditionally left out of research to date. And of course, we could never do this without the generous donation of data from our participant and sort of their commitment to our program, as well as the dedication of researchers who are actually using the data on the back end. So with that, I'd like to say thank you and take any questions you may have. The next session we'll talk about in just a minute, but I'll stop here and take questions that folks may have.
Yes, thank you so much, Dr. Scully. So again, we've had a very active chat, and we're very excited about answering your questions. So please keep those coming. We still have some additional time to answer them. I'll give some reminders again about some of our upcoming sessions. So if we've definitely given you a lot to think about, you want to learn more, great. That was really one of our main goals with this first session. So if you'd like to learn more, the next session will be held April 12th at 11 a.m. to 12 p.m., same time, same channel. But next week, there will be no one of these sessions because we'll be hosting our researchers convention. As Dr. Scully talked about, it's going to be held the 3rd and 4th next week. So please register. It's going to be a very well-attended event. And if you were thinking of this is all great, but what does the data set look like in action? That is a fantastic way to see how other researchers have used really the wealth and resources of this data set. So with that, I think we have some additional time for questions, and I think we'll answer things in the chat if anybody has anything to ask us.
Yeah, so I'm happy to take the few that are here. So for our health-related return of results, as well as our pharmacogenomic results, those are actually derived from our whole genome sequences. The ancestry and traits actually come from our genotype chip, which is a 1 million SNP chip called the diversity array that was especially designed for all of us, and now it's commercially available through Illumina. More ancestry results are offered than hereditary or medication results because they're sort of the first step. So eventually, we hope that those will be evened out and everyone will have everything offered back to them, but there is a little bit of a lag there. And so we start out with ancestry and traits, and then folks get the hereditary and medications. So that's sort of why there's the lag there. Beth, I love your question. One of my other many hats is tracking how many NIH grants have come in proposing to use all of us resources. And so in addition to several funding announcements that both Ruben's group and my group have put out, we're actually tracking who's coming into the parent R01s, R03s, all the grant mechanisms, because to us, that's part of the ecosystem of research, right? The funding piece. We'd love to be able to expand beyond just NIH grants. I'd love to know what foundations are actually funding folks to get in here and use the data and things like that. So it is an active area that we are looking into. And I see that Ruben is answering Brian's question about citizen scientist. So the reason why we haven't been able to fully launch the citizen scientist yet is exactly the point that you raised there, Brian, that you have to have an institutional agreement, which when you're a citizen scientist, who's your institutional agreement. So we're trying to figure out how we can actually validate citizen scientists and they're actually people who they say they are. And that's something we're working through, but Ruben might be able to give you a more thorough answer. Let's see. How much of your data is reliable in different aspects and from different continents? I may have to know a little bit more about that question. Certainly with any resource and any data type, there will be holes in the data. There are going to be people that we don't get survey responses from. There are going to be holes in our electronic health record data and who we're able to get responses from. And, you know, this is something that we're trying to really document with documentation and make sure people understand what's there and what's not there. That's sort of where we are with that, just understanding that there is going to be some differences. And then Reagan asked about epigenetic data. So Reagan, we're not actually doing an epigenetic chip right now. It is something that we're definitely interested in doing on a subset of our population that has not been done yet. There is some methylation and epigenetic data available in the long read sequences that we're doing. Those are actually 80x coverage. And so you can glean some insights from there, but we are considering doing epigenetic chips on a subset of our individuals. And do we have any awards or funds available for intramural programs at NIH? I would love to talk more about that. We were able to do that for an extramural set of folks, and we got tremendous input from not only the research community applying for these, but also our NIH institutes and centers who actually help fund them. So it was a really, it's been a really great thing for us to do for extramural. I'd love to talk about how we can do that, the same sort of thing for intramural here. And so if anyone has any ideas, feel free to reach out to me or Ruben. We're happy to sort of chat through potentials there. And yes, there is bias in our sampling. As I mentioned before, we are not nationally representative. And I think making sure that we're very clear about that and that we're bringing in sampling weights and other things like that. So we can be more comparable to sort of nationally representative samples will be the key there. But, you know, right now we are purposely not representative of the US. And so not only the geographic locations that you mentioned, but also with how we're going about recruiting our participants.
I'm just checking to see if there are additional questions.
Yeah, one just popped up. I would actually have you check with your IC about whether or not they have a data use agreement, which they likely do. Each different institute and center actually has a representative that is in charge of sort of data use agreements with all of us. And I think if you got in touch with one of us, we can help you figure that out. I'm always hiring talented people, so we're trying to get talented people. It's a lot of work to do. All right, Ruben or Cindy, you want to take over?
Yeah, Dr. Soley, thank you so much. That was really wonderful. Thank you so much for presenting all of the data. I think it's a fantastic resource. I really appreciate you being here to share it with the NIH community, and I'm glad to see that there is interest from the intramural community. I thought that would be the case. So I also just want to remind people that you need to register for each seminar sections separately. So if you have not done that already, go ahead into the library website and to our classes and register for the rest of those sessions, because I think you'll find them equally as valuable. But thank you so much for being here, especially right before your own research conference. I think it was really very valuable information for all of us.
Thanks for having me.
Yeah. All right, thanks. Bye-bye.
Again, bye.